Good afternoon, everyone. Although this is a tribute to John Linberg, I wanted, on behalf of the Argentine Society of Ocular Plastic, to thank John for accepting this tribute. And I compare it to, if I wanted to make a tribute to Maradona, Messi, or Pelé, because we have some Brazilians here in my house, they will surely say no. So for us, it's an honor to have you here and having accepted this invitation. I also want to thank Daniel, Martin, and Eduardo for participating tonight. And as we have a very tight schedule, I'm not stealing more time. I just want to remind everyone that we have a simultaneous translation, and you must tune into the Spanish or English option, depending on which language you want to hear. This is on the button near reactions. And also that if you have any questions you may want to ask the panelists, you write it on the chat, and we will ask John if we can at the end of each lecture. Now, Daniel and Martin, go ahead with this tribute, and thank you again very much.
Thank you, dear John. It was a history behind us and behind a lot of people. I met you in Campinas in Brazil in 1991. And then I knew the endoscope. After this, the other year, I buy in Spain an endoscope like yours. And I have this endoscope with me and you, for you. I use it in the office. And bueno, we are learning from DCR endoscope or Jones endoscope surgeries.
Okay, so we're very pleased to have John here, and this is, as Rodrigo and Daniel just said, it's a tribute to him. We've known his work for a long time, and it's a good thing to have him here, even if it's in an online fashion. John graduated in 1971 from New York Medical School. Then he volunteered as a general physician for the public health system, serving the Indian population in the Indian Health Service. Then he did his ophthalmology residency at St. Luke's in Columbia University. And then he traveled to Jerusalem, where he worked at St. John's Ophthalmic Hospital. This is a public hospital that provides care to Palestinian refugees, and here he is given an award for serving at that ophthalmic hospital. This is a hospital where you have severely wounded people, and it's a great thing that people serve there to help refugees. In 1979, he returned to the US and started an oculoplastic fellowship at the University of Iowa. And he then joined the West Virginia Ophthalmology Department. And in 1994, he was elected to be professor and chair of ophthalmology. And he organized the funding and the building of the West Virginia Eye Institute that you can see behind. The university didn't have an eye institute before, and John was in charge of doing that. It was a great legacy for the university that he could help in funding and creating the eye institute. Besides all his career at the university, he published 2 books, did 84 peer-reviewed papers. He trained about 20 fellows and participated in 20 Orbis mission. And he was selected to give the Wendell Hughes Lecture at the Academy, at the American Academy of Ophthalmology. That's the biggest award or the most important lecture that you can give in oculoplastics. at the American Academy of Ophthalmology, and he was selected to be one of the presenters there. He continued to work part-time, serving the VA hospital and mentoring fellows. This is recent. And he enjoys spending time with his wife, Susan, and Jesse, and Vincent, his sons. He, for example, built his own cabin in the woods and took the trees down, took out the bark, and built the whole cabin from the logs to the windows and everything with his son and with his sons and his wife. He's a fan of motorcycle, and as you can see in most of you that have keynotes presentations, the picture where you have to place a picture is a Ducati. And this is a picture that comes in keynote, and he has a Ducati almost the same as you can find in every template in keynote. This is one that he rides, and this is one of his favorite motorcycles, a Norton Commander, I think it is. He might correct me because I don't remember every model. And he did two very interesting tours and competitions in Italy, one with another Ducati on the left, and this with a Vespa, where he won a trophy for 400 miles in the Moto Giro in Italy. So I think that is one of his most admired things in the motorcycle hobby.
¿En serio?
Very recently, ¿se escucha, Rodri?
Perdón.
Sí, yo escucho perfecto.
Bien? Yeah.
Perfect.
Very recently, we had the privilege of being at his home in West Virginia, where we had the Orbital Society meeting. And here we had a pleasure. He was the host for the meeting. And I want to thank you for that and thank him for being here. So let's start the tribute and let's listen to his talks. Thank you very much for being here.
Thank you, Martin. Beautiful. Bueno, now it's your time, dear John.
Okay.
You can begin with your presentations.
All right. So now can I make PowerPoint work? I sure hope so. Yes, so far so good. So you can see this, huh?
Oh.
Yes, perfect.
Okay, good. So again, thank you, for the invitation. I enjoy these things, and especially from friends. Now, but when I sent a list of my topics, and I got a return to talk about 5 of the topics, I thought, well, it's going to be a long meeting, but then I found out it's a short meeting. So I've been trying to practice. I don't think it's going to be very hard to do all of them. Maybe one will skip. I don't know. I'll go as fast as I can. We'll see where we are. Okay. So the endoscope, my involvement is not that I thought about, I think an endoscope would be a good idea. And then I went out and found one and used it. It really was just what they call serendipity, right? So I'll tell the story. I think actually the story is interesting. I started my fellowship in oculoplastics at the University of Iowa with Dr. Anderson. And he taught me to do DCR surgery and external. And he emphasized a big opening in the bone, at least 12 millimeters. And sometimes he'd get even more. And so then, of course, the patients are coming back to clinic with, very good results. But I thought, well, I'll just look in the nose because if we make such a big opening, I should be able to see it. And so I looked with a speculum and a head mirror, and I couldn't see anything. So I asked Dr. Anderson, I said, I can't see the opening. And he said, well, is there a problem? Is the patient doing well? I said, patient's perfect, but shouldn't I be able to see it? He said, well, I don't know why it matters, But he looked, he said, well, I don't see it. I don't think he looked with a nasal speculum once every 5 years, but at any rate, I said, but Rick, really? So he said, okay, you go down to ENT, the other end of the building, and they'll help you. So if there's one thing I did for the endoscope was I was stubborn, because I asked the patient if he would go down with me, and the two of us walked down to ENT, and the ENT physician, Dr. Bumstead, he looked in the nose with the speculum and he said, well, I don't see any opening at all. I said, well, that's my problem. So he said, well, you know, he took out an endoscope, which was a fiber optic endoscope. It was kind of fat, but he put it in the nose and he looked and he still couldn't see anything. Now, fiber optic endoscopes do not have very good resolution because the picture's divided up into pixels, you know, one for each glass fiber. And so he thought about it. He said, okay, so I'm going to go in the back. And he comes out with this old box and he says, now we don't use this anymore. We used to use it years ago. And but one thing, it's got very good resolution. You can really see details. So let's look with it. And he took out the endoscope, which, you know, we would call the endoscope, the Hopkins endoscope. And we looked at the nose, and sure enough, we saw this little opening about 2 millimeters, you know, which was a surprise to me and a surprise to him. And he said, you know, he said, we never use this, so I'll just give it to you. So he gave me an endoscope, and I took it back to the eye clinic, and I started looking in patients. So, you know, again, I didn't really know what I was doing, but it was interesting to me because I was looking at something that, I mean, you can't really see it with a nasal speculum very well, if at all. And so I started looking, you know, Jones tubes and stents and all of these things, but also many patients after DCR surgery. And they all had this very small ostia. And I thought, well,
John,
yeah.
John, sorry to interrupt. You were pressing, we didn't know if you were advancing the slides or not. Sorry.
Yeah,
Go ahead.
Yeah. So this was a picture of me from 1971 using the endoscope. This endoscope or telescope was invented by a British physicist, mathematician who worked in optics. He was twice nominated for a Nobel Prize in Science. Now, I didn't get it, but I mean, he was quite a good scientist and very interested in what everyday applications of his theoretical physics. For example, he invented the zoom lens, you know, used in TV and lenses all across the world. In the 1950s, he was working on transmission using thin glass fibers, you know, the idea of fiber optics. But he also worked in order to get higher resolution, because he realized with the fiber optic bundles, you did not get good resolution or very bright. And so he, in mathematics and physics, and he came up with his what were called rod lenses or Hopkins lenses. And these were long cylinders of very high quality optical glass. And then at each end, there would be a lens either ground on or cemented to this rod. And he found that he could use 3 of them to produce this quote unquote endoscope or telescope to look inside the body. That was it. He had this idea. He was a physicist. And the pictures was very sharp because most of these instruments had many lenses and a lot of glass air interfaces. But here he had 3 rods, really 3 of these little small air spaces. And then because, you know, he was expert with these fiber optics, he put a layer of fiber optics around these cylinders to deliver light, you know, into the body, and then you could look with the rod lenses. Now, you know, today this Hopkins telescope used in urology and in orthopedics, arthroscopy, laparoscopy, all minimal invasive surgery, just about everywhere, including in ophthalmology. But to the best of my knowledge, when I started using this in 1979, I don't think there was any other ophthalmologist in the USA or as far as I know, the world that uses an endoscope for anything. So, and Dr. Hopkins, he was very interested in application. So he sold this design to Shorts, who, you know, has made endoscopes ever since. And you're familiar with this. And I don't know what that is, but I'm trying to advance. So this is what I saw at first. And this is the lateral nasal wall, and there's a probe, and there's the DCR opening. And I knew that journals would never publish my reports unless I had pictures. And you know, there was no way to take a picture, or at least at that point. And so I decided I'd work on that. I'm sorry, I'm going to go past this. I'm going to try to go. So I sort of did this. I took my own camera, single lens reflex camera, and I put the endoscope on the front of the lens, which, you know, I adjusted to infinity, and I taped it on with duct tape. And then I took the flash from my camera, this right here, and connected it with a Y-shaped. So these were available in surgeries, Y-shaped fiber optic bundles that they used for headlights and illumination. So constant illumination came from the light source. And then when I wanted to take a picture, the camera would tell the flash to flash, and I would get a burst of illumination sufficient to take a picture, right? So this is not a good picture of it, but, you know, it was just, so, you know, it wasn't very complicated. I got better pictures the more I had practice. And, but, you know, so the first thing we observe is that even though we made this large opening, 10, 12, 14 millimeters, the final opening is quite small, at least in the patients I saw. And here is a patient, you know, about 3 weeks, and the, you know, the final result. There were a few patients with a little bit bigger, but most of them were small. And so I was using the endoscope to look at patients pre-op, looking for problems, and then after surgery. And, you know, later I could say, well, all that time I spent helped me because there's some skills involved in using the endoscope. And so later, you know, they worked out to my advantage. Now, I would say at first I found the endoscope most useful for problems like here's some stents with a granuloma that, you know, the granuloma should be removed and treated with steroids. Here's a Jones tube that's too long, hitting the nasal septum. Let's see, one is almost too short. This one was repeatedly getting blocked. The woman wore a lot of makeup and mascara, and so it kept blocking. You see the black, but you wouldn't know that, you know, without an endoscope, I don't think. So anyway, I thought, well, this is useful. Now, some other people, so I love this. If I do a report and then other people, they take a different attitude, they go in a different direction. To me, that's the best, right? You plant a seed and then you don't know what's going to grow. I think one thing my study showed, well, you could drain tears through a very small opening. So I'm going to ask everybody a question, you know, answer in your mind. What volume of tears is produced by an adult, you know, healthy eye over 24 hours? You're thinking of a number, right? So there's been very good research showed that the volume of a normal adult is 1 1/4 milliliters per 24 hours, 25 drops a day. So obviously a small opening would be more than enough to drain those tears. Now, some other people thought, well, if a little ostium is okay, then maybe we just should make a small opening within the nose. Of course, my first thought was if you make a big surgical opening and you end up with a little one, that if you make a little one, you're going to end up with an even littler one. But, it turned out that the truth is somewhere in between. The first people that tried to do this did it with very strong lasers. This seemed like a good idea, endoscope plus laser. But I'm not gonna pursue then the application of that, because we have another speaker on the subject of DCR. There was one other point I wanted to make. I'm having trouble remembering it. But I keep an endoscope in clinic, and I like to look at patients before, and after surgery. You can see where you're going to work and what happens afterwards. So I know there's something else on my mind, but it's not coming to my mind. So, and the endoscope certainly is part of a lacrimal workup. And I don't know when I started. I don't know how long that took. Are there questions? Well, we probably don't have time for very many questions. So I did, when you get to be older, right? I'm 76 years old. The first time I went into an operating room was 1969, right? Wow, 50 years ago. And it was exciting then. And every time I go in the operating room now, it's exciting to me. So I'm addicted. I love surgery. And I never meant to be a lacrimal expert. It really happened by accident. I published that paper from my fellowship, and then a few people asked me to write chapters, and then I did another paper, and all of a sudden, people are asking me to talk about lacrimal disease, and I'm happy, I'm young, and anything, I'll talk about anything. And so I didn't really mean to become a lacrimal expert, but I guess that's part of my reputation. And so I began getting referrals of patients with tearing. And orthopedics get patients with back pain, and most of them, they can't help. And lacrimal surgeons get patients with tearing. And so the first thing I'm going to I just want to talk about what a perspective that I have learned, which I try to teach. It's not very sophisticated, but it has been very kind of helpful to me. And I try to teach it to the residents and the fellows, because often I'll get a call from a doctor who says, I have a patient with tearing and it's patent to irrigation. Okay. And then the patient comes and the resident goes and comes to see me and says, we have a patient with tearing who's patent to irrigation. And I said, well, what about everything else? Well, it's patent to irrigation, so no problem. Of course, there's a lot more to the story. So I'm using the most non-specific term. I'm going to talk about the first steps in the evaluation of these patients who were sent, quote unquote, with tearing. And the first thing I really have learned is that patients only have a certain number of words that they know. For example, they don't know the word epiphora. And with their vision, they don't know, words like metamorphopsia, or they only have a few words. And some of the words can be confused with lacrimal symptoms. So they may say about their vision, it's blurry or it's fuzzy. Well, we understand that. But I feel sorry for the translation lady now, because it must be hard to, some patient says misty, foggy, watery, bleary. Well, these are not very specific terms. And for these patients with just a little bit of trouble, the physical findings are often, not real obvious. So the first thing I've learned, I try to teach my technician is, oh yeah, she's smart. She's, bring these patients for me to see without doing anything to them. No drops, no dilation, no intraocular pressure, don't check the pupils, don't shine any bright lights, because it all will change lacrimal secretion. And they have a complaint. I want to see them the way they are in everyday life. Now, I do ask for a careful refraction, which, we hardly ever do in oculoplastics clinic. I recently, some years ago, I started working, we have a free clinic downtown, and I have to refract people there. And it took me a while, but actually I sort of enjoy it. Anyway, I do ask for a good refraction, because so often then when I see the patient and their vision will not refract to normal, and I ask them, why are you here? So I say, well, I can't see good. So, I've kind of done a lot of talking about this early part, but I think it's important. So then as I walk in the room and shake hands and tell them my name, I'm looking at the face, and I'm looking in particular at the tear meniscus, and they haven't had any manipulation. And after I look at the face, then I do a slit lamp at low illumination. And these two things often lead to a pretty good idea about the diagnosis. So let's see here. Sometimes it's, it's fun, it's so obvious. This young woman has a mucoid, when I push on her lacrimal sac. This woman has a fistula. And here we have a seventh nerve palsy, but some of them are quite mild, and punctal eversion and mucus. This patient I only have one patient with this presentation. He came to see me. I said, why are you here? He said, my eye is bleeding. And I looked at his eye. There was no blood in the tears, no blood in the eye. I said, I don't see any blood. He said, well, in the morning, I have blood on my pillow and on my eyelid. Oh, I said, well, come tomorrow, bring your pillow, and also don't wash your face, just come. And I saw him, and sure enough, so we had this area where the tears would overflow and then they would dry and leave behind these blood cells. So this is the closest I've ever seen to bloody tears, which we all learned is related to tumors. And in fact, he had a lacrimal sac tumor. You may be able to appreciate this right here. So just a thoughtful external examination. And then the slit lamp, and in particular, looking at the tear meniscus. So I tell the residents, when you look at the eye, you look at the anterior chamber, you look for cell and flare and blood. And when I look at an eye, I look at the tear meniscus. How big is it? And is there stuff in it? So like the cell in the anterior chamber, is there debris in the tear meniscus? If it's increased in size, usually I can see it. And it's not normal, because normally the lacrimal drainage system is designed to remove debris. But if there's any impairment of lacrimal drainage, the tear meniscus will fill up with little pieces of mucus and cells, and you can see it. And then we know the normal physiology is that when a person blinks, the orbicularis muscle squeezes tears out of the canaliculus into the sac. And then as when the eyelid relaxes and opens, tears in the meniscus run, from lateral to medial into the punctum and into the canaliculus. And if you have debris in it, you can actually see it happen. So you say blink, and then they open their eye, and all of this debris actually will shift medially and then stop. And then they blink and it repeats itself. If there is no lacrimal drainage, that it won't move. You'll blink, and the little particulate matter just sits there. And at that point, you'd be pretty sure there's some actual functional obstruction or impairment of lacrimal drainage. And of course, we look for other things. I'm going to say something that I don't think anyone will agree with. Which I enjoy that, of course. You know. So Dr. Linberg says, dry eye syndrome does not cause tearing. Now, of course, if somebody has filaments or ulcers or, you know, bad epitheliopathy, and that pain can cause reflex tearing. But there's so many patients, I see anyway, who complain of tearing and have been told, well, you have dry eyes and the drops don't help. Now, what I think happens is that ophthalmologist sees a patient in a busy clinic that complains of tearing, and they maybe do an irrigation and it's patent, and they're not sure what's going on, you know, but they would like to finish this exam. So they say, well, you know, sometimes dry eyes cause tearing, and I'm going to give you some artificial tears. And that's the end. Of course, the patient is thinking, this doctor isn't very good. You know, I mean, my problem is I have too many tears, and he's telling me I don't have enough tears. Well, again, if the cornea is normal, I really don't think dry eye causes tearing. Usually there's a very diminished tear meniscus and staining of the conjunctiva, other signs of dry eye. So that's what I believe. Probably no one else. I've tried to think about how to study it. It would be very, I think, difficult. But as under the slit lamp, we look at the punctum and maybe there's canaliculitis or absence of a punctum, a little tumor, and conjunctival chalasis, very popular now. Residents all make notations about conjunctival chalasis. Yeah, I think it rarely causes tearing, but you know, I have at times done surgery to remove a strip of conjunctiva or simply take a hot cautery and shrink it. But it rarely is, like, you know, really therapeutic, I think. Now I'm just talking about, you know, the initial approach to the patient. I've introduced myself, looked at their face, looked with a slit lamp, and then the next thing, which I think is, you know, sort of the best lacrimal test, is the fluorescein dye disappearance test, because it's painless, quick, physiologic, and very sensitive. It is not a Jones dye test. I haven't done this sequence in, I don't know, 30 years. I doubt any of you have. But it's in the books, isn't it? The dye disappearance test is the most useful if you use a standard drop and concentration. So in other words, not those strips of paper that have a little fluorescein on them, because then you'll put a different amount in each eye, so that you can get these dropperettes, or you used to be able to get them 2%. And so you're putting one drop in each cul-de-sac. And I think this is something you can do. You almost don't have to just say, but I'm going to give you an eye drop now, and this won't hurt. And I'm still asking them about symptoms. So this was, I wanted to take a picture. So I asked my technician if she would help me. Now, this was when I had a standard, you know, film camera. So you have to advance the film. So I put a drop of this fluorescein in her eye. By the time I picked my camera up to take her picture, a lot of it's gone. Then by the time I advance the film and take the second picture, in essence, it's all gone. So this is the normal, young, middle-aged adult lacrimal drainage system. It's very quick. And so, you know, that's what you'd like to see. A different way to show this is I put a drop in each eye, waited about less than 60 seconds and took her picture. There's no delay. Then I put a temporary punctal plug in her upper punctum, did the same thing, and you see a big asymmetry. And the point in showing this is the test is quite sensitive. She still has lacrimal drainage. She doesn't have epiphora, right? She has a upper punctal plug. She didn't complain of tearing, but her dye test was quite obviously abnormal. And then I put a punctal plug in both puncta, and she had both tearing and delayed dye disappearance. And I usually use just regular ambient light. It's easier, I think, to see color density. You want to look at the sclera. You can see a very small difference in the amount of fluorescein on the conjunctiva in one eye and the other. The blue light, I guess sometimes if you maybe use blue light, I basically don't use the blue light. Some people advocate it though. And the other nice thing about the fluorescein dye disappearance is to use it in kids. You may have a fight putting it in, but then this boy I'd done a probing on, obviously a minute later the dye's gone. So, okay, he's painting. And furthermore, it's coming out his nose, right? So the dye disappearance test it's a good, useful test. So, the advantages is quick, painless, physiologic. And if you want to show it to the patient, you can. You get a mirror and say, look, one eye is yellow and the other one isn't. Disadvantages, it doesn't tell you where the obstruction is. And in older individuals who have a low tear production, they will get staining of the conjunctiva. It's not in the tear film, but actually in the tissue. And so no matter how long you wait, it will appear that they have retained dye. So you just kind of then look with a slit lamp and try to see, is there dye in the tear meniscus or just in the conjunctiva? So this was not at all the full lacrimal evaluation, but given 10 minutes, I wanted to cover what I feel like I've learned in terms of early in the encounter, before spending very much time. I've looked at the patient, I've done a dye test, and I have a pretty good idea whether, because if a patient has a normal dye disappearance test and a normal tear meniscus, I think it would be very rare for them to have any lacrimal disorder. Maybe if they had a dacrylith that was intermittent. Other than that, and I often won't proceed any further. It looks good to me. I think you're okay, and come back if you have trouble. So I have a longer talk on all the different aspects of lacrimal evaluation, which I am not talking about today. So if I understand correctly, we are going to now get a talk about endo DCR. If I'm right, I'm going to stop my share. Thank you for teaching me that, Danielle. Anybody hear me?
Yes.
Okay.
Well,
Perfect.
Thank you.
Beautiful.
Thank you. Thank you very much.
Toca a vos, ¿no?
Edu,
Yes. Hola.
well, now Eduardo Rubin is a doctor that very close friend to all of us, and he will talk about his experience with endoscopic surgery. Go ahead, Edu.
Okay. Okay. Can you hear me?
I can.
Okay,
Perfect.
bueno. Thank you very much. I'm trying to. Sorry. Well, thank you very much, Daniel, for inviting me to be part of this special session where the Argentinian Oculoplastic Society honors Dr. Linberg. That is a legend for us. And I want to share my experience in endoscopic DCR. Probably, Dr. Linberg, you were one of the first ophthalmologists in the world to use an endoscope to see the lacrimal system. And I think I was the first ophthalmologist in my country to perform endoscopic DCR. It was in 1998, after finishing my training in oculoplastic with Daniel. And in this day, we were looking for a scarless surgery to be used in young people and in children mainly. And the cosmetic result was the most important motivation for us to go ahead with this kind of surgeries. And we had to become familiar with a new world of the anatomy of the nose, and we have to learn the anatomy and anatomic landmarks as the nasal septum, the medial turbinate, the axilla of the turbinate, the projection of the agar nasi, and this line that is very important is the M line, that is the limit between the frontal process of the maxilla and the lacrimal bone and the fusiform process behind. And you can see the projection of the lacrimal sac and nasolacrimal duct in this site. That is our preferred site for making our osteotomies. The technique is especially useful in children like this 1-year baby. And after making a nasal flap and removing the mucosa and exposing the maxillar bone, we proceed to the osteotomy with the Carrison rongeur. And we can easily make the osteotomy because the maxillar bone is very thin in the children. And then we use a lacrimal probe to obtain some tension. And we open the sac, we open the lacrimal sac, and you can see the content of the sac. And after this, we use a scissor to make 2 flaps, one anterior and the other posterior, and we proceed to open the sac and to put a bicanalicular intubation state, and you can see the common canaliculus in the lacrimal sac in the nose. And this is important to see when you finish your surgery, the common canaliculus. And at first, I remember that at the beginning, I used to choose only patients with a smaller lacrimal sac because we believe that it was impossible for us to make big osteotomies to deal with large lacrimal sacs like this from the nose. Then we developed, we learned more, and we understood that the limitation was in our mind, and we improved our technique to perform large osteotomies that allows us to see all the lacrimal sac. We remove all the bone we need to expose the whole lacrimal sac. You can see the lacrimal sac inside the nose. And after removing all the cheek bones, all the little bones, we proceed to open the lacrimal sac. And it's important for us, after removing the contents, to remove tissues of the lacrimal sac to obtain a smaller one, especially when we have acute dacryocystitis. We are removing the redundant lacrimal sac, and we are opening the flaps. You can see the inflammatory process of the mucosa of the sac, and then we put and stent and replace the mucosal flap. So with this technique, you can perform the surgery even during an acute dacryocystitis with a very big lacrimal sac as this, and you can obtain in a few days a very important improvement in your patients. And here you can see another case on the children with a very big lacrimal sac. We proceed to remove a dacrylid that is inside the lacrimal sac. And if you make a big osteotomy, you can remove as much as lacrimal sac as you need, and then you can put your bicanalicular stent. And after finishing, you have to be sure that you don't have any residual sac. You have to open the whole lacrimal sac to obtain the better results. With endoscopy, you can easily identify the development of a big agar-Nazi cell that is interposed between the lacrimal sac and the nose, and the bone of the nose. And in these cases, it's useful to remove the agar-Nazi cells. We are making this with the Kerrison. You remove the cells and the mucosa, and after this, you can complete your osteotomy as usual and make the opening and exposing of the lacrimal sac to complete the endoscopic dacryocystorynostomy as you do. Now we have removed the agar-Nazi, we can better see the lacrimal sac, and we are opening with a knife. The endoscopic technique is also useful in obstruction of the common canaliculus like this. We use a trephine from Visitech, and we put the trephine from the upper canaliculus, and we see the trephine inside the lacrimal sac after we open it like any endoscopic DCR. And then we put a bicanalicular stent that remains 3 or 6 months. And in most of the cases, you have an improvement of the tearing of the patient. Here we have videos of postoperative endo-DCRs. You can see a very big fistula here. And you can see the tearing when you push on the lacrimal sac. And in another case, you can see the fluorescein inside the nose when the patient blinks. And of course, you can have failures in your procedure, especially due to synechia of the mucosa of the nose. So you have to remember that the nose, we will treat you in the post-operative period the same as you treated the nose during the surgery. So you must be careful and you have to work very slowly. In summary, I think that endoscopic DCR is the new gold standard. We can obtain a scarlet surgery. It's very useful in big sacs, in acute dacryocystitis, and I think that it's not the future. I think the endoscopic DCR is the present and is the procedure that will open the doors for you to go ahead and perform orbital endoscopic surgery and maybe school-based surgery. Thank you very much. It's an honor for me to be present here.
Thank you, Edward. Thank you. Very nice.
Daniel, do you want to go ahead and do some questions? I have 3 good questions.
No, make you the questions, Martincho. Yes.
Fernando Colombo has very good questions that I think Dr. Linberg and Edu can give us their opinion. One is, do you think that mitomycin C has any role in endo-DCR? or external DCR, I would say also.
I've only used it on reoperations, and I'm not sure if it helps or not.
I also use the mitomycin only when I have reoperation on, or if I had a synechia and if I remove a synechia to reoperate a patient, I use the mitomycin. I am not sure if the patient improves because of the mitomycin or because of the tear going through the fistula. I'm not sure.
I think that Angela Colombo has a paper on mitomycin C in pediatric endo-DCR, where she shows that it improves the outcome. I also use it for
yes,
recurrences.
But also have another paper, Angela, saying the opposite.
Okay. Do what you want, guys. Anybody has any opinion on the transcanalicular laser DCR?
I have no experience with this. I spoke with Gorka in Spain. He used to perform endo-DCRs with laser. He had a lot of failures, more than 50% of failures.
I made 5 cases only when I was in Spain, and all was a failure, because I suppose the one is the hot of the laser, and the other problem is a very, very small osteotomy.
Yeah,
I think
Thank you, guys.
I think in theory, the successful healing of a osteum is a race between the epithelium to cover the defect, because then it is stable, and the tendency of the tissues to contract, the soft tissues. And what has always puzzled me is I think mitomycin is very toxic to epithelium. So I don't know. It's like if you put it on the epithelium, it will grow more slowly into the osteum. But that's just talk. It doesn't really prove anything. I did want to, and there was a moment ago that I said there was something I forgot. And what I wanted to say is the Hopkins endoscope had fallen into disuse. But then when people wanted to do surgery with an endoscope, they can't use a flexible endoscope, because the minute you put in any kind of instrument to do surgery, you hit against the endoscope and you lose your view. But the Hopkins endoscope, you can hold it firmly and you can use other instruments while you maintain your field of view.
Excellent. John, I think you can go ahead with your next lecture so that everybody can arrive to dinner at some point tonight.
You eat late, right?
We have dinner late at 9 probably or something.
Yeah,
No problem, John.
Well, but seriously, by my understanding, we should be done in 25 minutes. I can't do it. Well, I'll give this talk, and then you can tell me what to do. Oh dear, John, what did you do? There we go. So while I was finishing my residency, the story is always sometimes more interesting than the place, but in any event, I was doing a residency in the middle of Harlem, a very rough, African-American, very rough area, a lot of patients. But right across the street was this old, large cathedral, the Cathedral of St. John the Divine, which was Episcopalian or Anglican, in other words, not Catholic. And, in the middle of really all of this chaos, violence, and everything. So I began sometimes at lunch or at noon, it was just across the street. I'd go across the street and go sit in the church for a little bit, not because I'm particularly religious, but just peace and quiet. But, you know, the clergy there, man, he noticed me. He kept saying I was there. And then I found out there was a little garden. He went behind the altar, there's a little garden back there. And I started bringing my lunch to eat in this little green spot in the middle of Harlem. And he would talk to me. And when he found out that I was training to be an ophthalmologist, he said, well, John, do you know about our eye hospital in Jerusalem? Would you like to go and work there? And so this, you know, this is my fundamental assumption. I said, yes, you know, just say yes. We had a president, Ronald Reagan, very conservative, and his wife thought she could help with the drug problem. She had a program called Just Say No. And the idea was that someone who was an addict or whatever, that if they would just say no, then everything would be fine. You know, didn't quite work that way. But so my version is just say yes. So when he asked me, oh, would you like to go work in Jerusalem? I said, yes. And there's some risk because at that time and now there's some obviously violence, but it was not risk averse. That's an English thing. I wasn't against risk. I actually think risk is interesting. But so I'm going to tell you, so that's interesting. I mean, if you're in the middle of Harlem and somebody asked me if I want to go to Jerusalem to work in an eye hospital, it's an amazing story. So I did, I went. And so this hospital, the history of it is, I think, just, again, surprising. I'm going to tell you the story. So in the Middle Ages, right? In the Middle Ages, all of Europe and that area was mostly Christian. And before the Reformation, and the epicenter in their mind and their view of the universe was Jerusalem is the center. And this is a 13th century map of the known world. And the very center is Jerusalem. And they make everything else, you know, fit around it. And so when Jerusalem was occupied by Islamic armies, let's see here, the Pope announced that it was important for Christians to go and take back Jerusalem. And so he asked for a crusade. And so from all over Europe, every little feudal state, or sometimes they were called priories, would send a knight or two, and they would provide horses and armor and all that. It took a long time, though, to go from Europe to Jerusalem, right? Cross land, and then from Venice in boats, but they arrived. And actually, they retook Jerusalem fairly easily. And then this terrible thing happened where these Christian crusaders who had just arrived offered every person who lived in Jerusalem the opportunity to convert to Christianity. And anyone who didn't want to was beheaded. And this went on for 3 days, according to, you know, accounts. It's hard to imagine much worse. It's interesting. So, you know, recent years, sometimes these people in ISIS, they'll behead some person. Well, where did that come from? And they will talk about the Crusaders. You know, that is still part of their history in their mind. So, right or wrong, you know, it's not that they're good people or anything. But anyway, so here's a Crusader, you know, leaving to go to Jerusalem, and so when they arrived after they won this battle, there was a small, it wasn't really a hospital, it's called a hospice, a place where travelers, especially travelers coming to Jerusalem to see the holy sites, could rest. And they had this 8-pointed cross, and a group of these knights decided, and the hospital was called St. John's Hospital. And they decided they would expand it, rebuild it, and provide care. Was that a little guilt to it? We don't know. But they began to do this, and then the Pope found out. Now on my screen, the part of the writing is covered up at the top. Maybe you don't see that. I hope not. But I gotta move quicker. So the Pope said that he would ordain a new order, and it had a long name, the Order of the Hospital of St. John of Jerusalem, and that this order could train and ordain priests. They could collect tithes, taxes, make their own coins, and this is the essential necessity of government, to make money and collect money. And then they had their own, they could select their own leader, and they could have an army. And this served to protect Jerusalem. And so the founder was St. Gerard, this guy right here. And so for about 200 years, they maintained and they became more wealthy and more powerful. And they maintained this hospital, right? And so if you go to Jerusalem, I wish I could ask, who has been to Jerusalem? It is, I think, one of the most beautiful places and beautiful experiences that I've had. And I believe when I go and I'm in Jerusalem, there's a feeling, because it's the holy place for the Jews, you know, David's temple, the Wailing Wall. It's holy, obviously, for Christians. There's the sepulcher where Christ was laid. And there is the Dome of the Rock, where, as I understand it, Abraham ascended into heaven. So Islamic, Christian, and Judaic center. And there are all of these nuns and priests and every possible religion. And there's a feeling in the place that I offer you that if you go there, you won't be disappointed. So this hospital was there. So I took this picture from the top of the Lutheran bell tower. You could look down at where the hospital was, in the middle of the old city. The old city has a wall around it, quite small, really. And so, but eventually these knights were driven out again. The Sultan returned with his armies, drove them, but he let them get in their ships and leave. You know, he didn't kill them. And eventually they returned to Malta. Now, Malta wasn't a country then, it was just an island, but it was given to, they received, that is, the order received this land, which is now the country of Malta, and they built a city from nothing. There was just nothing there. They built a city, Valletta, which is the capital of Malta now, and named after the Grand Master. At that moment, they continued making their coinage. I visited this some years ago, and this whole castle is still, not castle, fortification is still there. And they stayed there until Napoleon arrived in 1798, and he drove them out, and the leadership went to the Vatican. And right today, inside the walls of the Vatican is a small little area, which is a sovereign nation, the sovereign military order of the Hospital of St. John. You can go there. It's the smallest, I believe, country in the world. But many of the other knights went back to their homes, for example, England. And so it's a complicated history that I not belabor, but Queen Victoria in about 1850 sort of reconstituted the English or British arm or tongue, they call it, of this order of chivalry. And she named it, you know, the most venerable order of the Hospital of St. John in Jerusalem. And then she instructed everyone to make an eye hospital, and no one has a clue why. So she established this order, reestablished it really under, Anglican Church rather than under Catholic Church. And she sent her son to buy or to build a building, and they built this building just outside the walls of the city. Here's a picture of it. It still stands, and this was where the eye hospital was initially located. It's now a old hotel, kind of run down, but I stayed there, 3 years ago. It's like going to an old movie, going to Casablanca. It's really just wonderful. So this building that was the eye hospital is now a hotel. But it's so at the time it was opened, they'd stated that they would always provide free care to anyone, regardless of their religion or their nationality. Kind of an unusual statement. And the rabbi of Jerusalem welcomed them because they were going to take care of everyone. And so there has been continuous free eye care to anyone up until the present time. It's pretty amazing. And they sent their first ophthalmologist in 1883, and after a year, he sent back his report, his annual report. And later, I found out that this went back every year. They sent their annual report. And at one point, when I was in the order, I sent a letter to the archivist. I said, hey, could I come and look at these, these reports? It would be interesting to see the change from 1883 to 1920 or whenever. And a month later, I got this big, heavy box with a Xerox copy of all the annual reports. And it just again, full of fascinating information. When that opened, you'll notice it took care mostly of Jewish people, then Islamic, Muslim people, then these were Catholics, they call them Latins. And the amount of pathology is quite amazing. And then in 1960, this man, Sir Stuart Duke Elder, the man who wrote the 17-volume, consolidation of the knowledge of ophthalmology around the turn of the century in the 1920s, he raised money to build a new hospital, which is still in use. I know now residents, almost no one reads his books, but these, before knowledge was stored in the cloud and the internet, it was stored in books. And he wrote 17 volumes and combined or compiled the knowledge of ophthalmology as it stood in Europe at that time. And he became the chief officer of this hospital, called the warden. He had his own little house next to it. It's all inside a wall. And he would come every winter and he would write his books. And now I wanted to get away from that. So this is they called it the bungalow. And here's the desk where he wrote these books. If you've seen them and read them, you'd kind of be amazed. And, in those days, more people read them than I had. Not all of them, but I had read them. So I got to sit in his chair. I was very happy to sit in his chair and write. Anyway. Seem to be in a loop, which is not good. Oh, so you just look at the, millions of people and hundreds of thousands of operations have been provided at no charge in this place. And the Americans who were members of the order began sending someone every year. And then, now it's on automatic. Huh? So in 1978, I went. Here's my team, right? And this was more fun than you can imagine because there were all of these patients And I just finished my residency, but there was no retina surgeon. So, you know, I was as good as anybody else who was available. There was no corneal special, so I was as good a cornea surgeon. So I did the corneal transplants. I wasn't a glaucoma specialist, but they didn't have one. And these patients could not get drops. So if they had, you know, bad glaucoma, I was told filter them. And so I did, you know, many filters. And of course they had, you know, bad cataracts, more patients almost than you can imagine. And I would operate Monday, Wednesday, and Friday and see patients on Tuesday and Thursday. And it was one of the great experiences and privileges of my life. If you can imagine this. See, so I show this because I try to recruit people, but it is all different now. And I've been back 3 times there to work roughly every 20 years. But here was a list. I had my 12 patients. This was a patient chart. So this patient had a detachment, and I made a little drawing, and I said, here's the hole, and then I did the surgery. This was the entire chart. So I wrote that. The nurses knew how to take care of people. They didn't need orders. They weren't trying to get any money from anybody. They just took care of people. And then the patient comes back, you know, a few months later, 2040, so that's the entire chart. And you can imagine how enjoyable and easy it was to practice medicine if all you had to do was provide care. And they, you know, had 2 ORs side by side, and as I finished one operation, they'd have the next patient asleep. I would just stand up and walk over and start the next operation. And you know, the British didn't use gloves. They thought that it decreased their, sensation of the instruments. But I insisted for like enucleations that they give me gloves. I did recruit this wonderful woman, Sharon, and she was there a year. Here's a picture of their clinic. You know, so they're still there. They have made a wonderful transition, and that is for all of these decades, they were dependent upon Western ophthalmologists from the United States or England coming there. And what they've been doing now for a little while is training Palestinians, you know, from the West Bank, first to be ophthalmologists. So they have a residency, and then providing them with specialty training. And so now they're taking care of themselves in this hospital. But this hospital is not, it's still in the Israeli land, right outside the old city. And there's tension over that. Israelis would like them to leave, but they've been there a very long time. So this is surely an amazing story in ophthalmology. This is the tunnel that runs down to the Holy Sepulchre where Christ was laid. And, you know, back when the Crusaders arrived, they all went to visit. And then as they were leaving, they would inscribe a little cross, each of them, into the walls. And so it's just covered with the crosses of these men who went there in 1099. And so you know, these experiences, so, you know, I'm an older person. I look back, you know, what were the important experiences? And for example, this was one of the important ones. So I'll get rid of that. I'm looking over here at my list. So somebody tell me what you want to do. I mean, I thought it was
a fascinating experience to be there.
Beautiful experience. Beautiful.
So you want to quit now? What do you want to do? It was supposed to be over now.
No. We want to go ahead.
Go ahead.
Okay, I'm happy, but I also know everyone has their life. Now I'm going to I guess, talk about something that, if I can find it here, not the addiction, but, and not that. This is where I had trouble this morning. And I don't want to make a mistake. But if I here we go. I think. Look at that. Okay. Come on, go away. 1 second. All right, get rid of this. Start my slideshow from the beginning. Okay. So, you know, again, as you get older and you look back at all the things you've done, and the thing that struck me was, you know, what were the very best things? And surprisingly, they were experiences not exactly part of the normal routine.
John, I don't think we're looking at the screen. We're seeing the selection of files there.
Oh my heavens.
You need to hit the run or something.
Okay, let me go stop this. Go down here.
Share screen.
Well, I'm not the computer person that I need to be.
Don't worry, we'll be there.
So this is the
I'll
power.
do it. Yeah, double click there. And
It's in the back.
Maybe
What?
over.
Maybe it's in the back of this
yeah, you can minimize that screen that we can see there.
screen.
I don't know how to minimize it.
It's over on the left.
Yeah, okay.
If you double click here,
Here?
if you double click in over the name,
Okay, I got to go back. Stop. Oh, over here. You see that? Do you see it?
Not yet.
Not
Not yet.
now.
No.
Yes.
There
yes.
you go.
Now,
There you
yes.
go.
Perfect, perfect.
Success.
Yes,
Done.
perfect. Yeah.
You did it.
All right.
No problem with the
That's what
time.
I'm looking at for the advanced. Maybe it'll show. Oh, there we go. Okay. So what has, and you know, my younger son decided he wanted to be a doctor, and his wife is a social worker. And I've been with them through the process. They just finished their residencies, not in ophthalmology. But there is in American ophthalmology anyway, what I call the railroad, that, you know, if you're on a train on a railroad, you go straight ahead, you can't really get off very easily. You're going to get to your destination as quick as possible, but you're on the rails. And it starts in college where they have to make very good grades just to even think about getting into medical school and take this test, the MCAT, and do well. And then they take courses to do well in the test. So they're not studying, they're studying to take a test. And then if they get into medical school, it just continues that they have to get really very good grades and board scores if they want to get into a specialty like ophthalmology. And so again, the focus is on getting good grades, getting good test scores, to get a residency. And then in the residency, they're worried about passing the board, so they study for this test, the ophthalmic knowledge assessment program test, in order to pass their boards. And if they want to get a fellowship, they have to, you know, have very good grades. And they often borrow money as American students. So they get to the end and they've been on the railroad the whole time, no time off. And now they say, well, finally, I'm going to get a house and a car, and we're going to have kids, and we're going to pay off our debts. And so we can't do anything except, stay on the train. Because the great fear that if you ever left the train, you might not be able to get back on, because I'm going to advocate that the best experiences that I've had in ophthalmology have been off the train experiences. The best, most inspiring, most fulfilling, and most joyful experiences in ophthalmology is when I got off the train. And so I say, just say yes. When I was in my residency, someone told me about a hospital in Nigeria, Mercy Hospital. They did eye surgery. Would I go? Well, I said yes. So I went to Nigeria for a while. After my residency, the man in the cathedral said, hey, would you like to go to Jerusalem? Yes, I would. I had a wife who was very amenable, but I wasn't getting to practice as soon as possible to get more money. Now, each of these places, provided me with food and a place to live, sometimes even a car. But now, when I talk to I spend a lot of time with our residents because we drive to this veterans hospital about an hour. So we drive each way together in the car, and I talk to them. And I tell them about my experiences, and they're very interested. But then they say, well, what do you think? You want to do some of these things? I say, no, it's not possible. Can't do it. And I say, but you're going to miss. The great thing about being a doctor is that all of these people in the world and in our own country that are poor and need help. And if you go and take care of those people, you can use all of your skills. You can do whatever, retina surgery or whatever. Use all your skills, and it's very fulfilling. But they say can't do it. I was able to get in touch with one Argentinian recent, I guess, fairly recent completion, finished residency and fellowship. And I told him about some of the things, and his response was the same. You're having a big recession. It's very hard to earn enough money to get along. It's just impossible. That would be a nice thing for Americans, but impossible for a doctor in Argentina. And maybe that's true. I hope not. To some extent, it's not only to say yes, but to accept that life has risk, and that perhaps you take risks. And I don't, making money, nothing wrong with it. But I think the reasons people say, or residents say that, I say, what do you think about the hospital in Jerusalem? Yeah, it's just not possible. There's not enough money, not enough time. And besides, I need to be careful. I don't want to be blown up in a bomb or something. They are risk averse. They're afraid of risk. And they're afraid of leaving this sort of continuous path. And there's also this crazy idea that ophthalmology is no longer a good job, that the government has ruined it. We don't make enough money. I was recently the president of the West Virginia Academy of Ophthalmology, and many private practice ophthalmologists were eating dinner. I don't know why I still practice, I don't make enough money, etc. Now, what they mean is not as much as the previous generation. They still go to the parking lot and get into a BMW to drive home. But anyway, it's been my observation that if you're willing to work, you go to work, you will make sufficient money to live in that place, right? I would say a friend here who I guess of all the doctors I've known in 50 years, the one who I admire the most, his name is Ivan Schwab. And he volunteered, went to Vietnam as a doctor. And after those years of just horrible, horrible work, and he got medals, and, you know, but when he got back and he said, you know, I have to do some good in the world. So he finished his residency in ophthalmology, and then he went to Africa with his wife and worked out in the country for 25 years, providing free care to these people. And they had 2 sons, and then they moved back, I don't know, 10 years ago. So, you know, I was tempted to put a number of things in that there's also sort of the political side, right? Of getting off the rails, of becoming involved in politics. You see me there? Or going to the Indian hospital. And you can still go in the Indian hospital. You get paid $99,000 a year. Yeah, I started so I'm going to jump through this because you know. Then I did become quite interested in Orbis because you could go so many places. It was just wonderful. The places I have been. I'm going to go back. So recently, while I was doing this talk, I thought, well, how much time have I spent off the rails? That is, the time in Nigeria, the Indian Health Service, St. John's, Project Orbis, some other places. And I just thought of another one. 2 nights a week for my entire adult life. But it came out to be about 10% of my work years. I didn't think about this. As I said, I'm not religious, but a friend of mine who is religious said, well, John, you've been tithing for, you know, the last 50 years. Well, I don't regret any of it. You know? So their decision, everybody makes decisions, and all I can say, I look back on my life and I say, you know, what are the best things? What were the best things of my life? They were these things off the rails. And I'm sure you're not familiar with Senator Lewis, a black man who, when he was young, he was a civil rights protester. He got beat up so many times, no one thought he would live beyond 30. But he ended up, you know, he died just a year or so ago. He's a senator. And he used to say, get in good trouble, by which he meant pick the thing you care about, climate change or voting, whatever you care about. And then he said, get in some good trouble. I love the man. So, okay. So, you know, I know, you know, Paul, you didn't come to this meeting to hear my philosophy of life, but I nonetheless gave it to you. So I have one piece left, and it's entirely
eager to listen to it, John. When you're in a tribute, you have to tell us what you think, and we love your stories and your insightfulness.
okay. So now, can I get this one to come up more easily? No. Where the heck? Where am I? It really wasn't that hard this morning, but nope, that's not it. Stop share, stop share. Where's Danielle when I need her? Huh? I'm sure she's right there telling me what I should do. Do you see this? Anybody see? No, you don't. Oh, that doesn't help. Because previously I had that, you know, my PowerPoints all lined up, and now I'm not finding them. So what should I do? There we go. Maybe. So Here we go. Do you see this?
Perfect.
Oh, very good.
Not the pictures, but
Oh,
the
list.
theme.
At least. I
So
think
not
we-
the pictures.
Martin, no problem if I don't give my presentation. That John gave his last presentation. I suppose it's the best
Okay.
for the time. Okay, no problem.
Okay, Danny, thank you.
Thank you. So I don't know what to do here. So try again. You don't see that? Huh? No, no one sees it.
Hey,
No,
okay.
yes,
You see it now? Yeah,
perfect, perfect, John.
perfect. Very good. Slideshow.
Financial disclosure.
Yeah, it's an accident. Don't worry about it.
No, no, it's a pleasure to hear you.
From the beginning. All right. So, all right. So this is surely the most personal thing I'm going to talk about in ophthalmology and in my medical life. Let's say I'm going to share a little bit of my history because hopefully it helps if you doctors can say, oh yes, I know somebody who had the disease of addiction and got better and then had a normal life, because often that isn't how it ends. And so my story is that in my late youth, I began drinking a lot. Everybody, I think, drinks, just, or many people drink, but I drank a lot. And then I began using other drugs. And, I'm a doctor. I have these skills. I started injecting drugs into my vein. And pretty soon, I was the full-blown typical drug addict. And I certainly didn't know what to do. And so at that point, I didn't know there was anything. I thought I had problems in life. I thought I used drugs because I had problems, and not that I had problems because I used drugs. This is a very common reverse, right? But in April of 1983, I went to a group, and you've certainly heard of them, that Alcoholics Anonymous. And you see them in movies, television. Often they look comical, right? But what I can tell you is, they, for one thing, they saved my life. But so this group, which started in 1939, two men, a doctor and a businessman who were both alcoholics, found what they thought was an answer. So medicine had almost no success treating real alcoholics, right? And these two gentlemen, they found a way. Now, I'm going to, again, it's short, but I'm going to make a couple distinctions, all right? One is the idea of being dependent on alcohol or some other drug. If you take anyone and you give them morphine every 4 hours for so many weeks, they are now dependent on that morphine. If they stop it, they go into withdrawal. They get really sick, right? So they are now dependent on morphine. That does not mean they're addicts. And this is important because sometimes people identified, as addicts are, and some, they had surgery, they start on drugs, they end up dependent. And then as they take more drugs, they develop tolerance, you know what that means. And when they stop, they go through withdrawal. And this tends to make them not want to quit. So now addiction is a whole additional and different thing. So I'll tell you a report that I think maybe helps. In Vietnam, in the war, many soldiers began using drugs, and they were cheap and available. I am a veteran, not a combat veteran, but at any rate. And they came back to the United States, and many of them were dependent on drugs. But in the United States, they couldn't get them. Vietnam, they get many drugs as they wanted, and they were cheap, but not the United States. And so the military created a program, first of all, to help them through withdrawal. Gave them necessary sedatives, and once they were done with withdrawal, provided some counseling and education about how they got into trouble and how to avoid it. And so, and then they went, they went back to civilian life. And 4 out of 5 did not return to using drugs. 1 out of 5 returned to drugs and could not stop.
Wow.
So you see, it's not just everyone who drinks a lot, not just everyone who uses drugs is an addict, but some people are. And so there's a lot of research about it being both genetic, and not going to take time here to try to go over that. But so some people, so I'm going to allege that some people have a disease called addiction. Now so many folks are of the opinion, really, that it's not a disease, even now, right? That it's a weakness, it's some psychiatric problem. And so the addict is seen as someone who just needs a little willpower. Nancy Reagan said, just say no, and they could quit if they wanted to. So so I'm going to call it the real addicts, ophthalmologists, they cannot stop. So after I told you 1983 when I stopped, and then a few years later, I had a good friendship with the dean because he also rode motorcycles, and he was having a lot of problems in medical school with medical students and physicians who seemed to have alcohol, drug problems, and he didn't know what to do. And so he asked me, he said, and it hadn't been that long, but he said, put together a group. So I got a psychiatrist who was expert in addiction, and a social worker who dealt with addicts, and an internist who's kind of specialized in the case. He ran a treatment center, and a couple other doctors, and we formed this group. And we looked around the country, the United States, to find, how do you approach the problem of doctors? Our doctors are ophthalmologists, but doctors who have alcohol or addiction. Alcoholism is just one kind of it. There is only one addiction disease. So whether one year I drank and the next year, I liked cocaine, it's the same disease. So we found our way over a period of years, and I chaired this committee for 20 years. So I got to know every doctor in our medical center who had a problem with addiction or thought they had a problem with addiction. And at the same time, I was very active in this other group, Alcoholics Anonymous, where I saw the non-doctor alcoholics. And I would spend about 2 to 3 nights a week in that community service group, as well as this committee. And we developed a program. And I want you to understand that, first of all, an addicted ophthalmologist, they won't respond to just a stern warning. It doesn't help. They must have treatment. Otherwise, it always progresses. It doesn't go into remission. It doesn't stay the same. It is progressive, relentlessly progressive. Without treatment, the ophthalmologist or the doctor will end up in prison or dead or in some mental institution. And their death is usually not, it doesn't say addiction on the death certificate. It says car wreck, suicide, liver failure, whatever. Often this physician's cause of death isn't clear because the doctor will lead a double life. That is, they want the most sort of important ethical commitment they have is to their patients. And so in their family life, often their alcoholism will have done all kinds of damage and will be obvious. But in their professional life, they will defend that part of their life. They will live, like, you know, the double life, the life at home where they drink and pass out, and pretty clear. But in the clinic, it may not be so clear. Now, this is a problem because these people need help. They need some intervention because they're not going to stop on their own. And as doctors, we've been conditioned not to interfere in the lives of other doctors, right? But this, an addicted doctor, otherwise, is a real threat to themselves and their patients. And so what is our responsibility, just ethically, or in some countries, ethically, I'm sorry, legally, if we see a colleague who appears to have a problem with alcohol, and I can tell you, if you see it in clinic or in the operating room, you can almost be certain it's many times worse in the rest of their life. Now, so I am going to keep this, pretty short. What is needed is, first of all, to make a clear and secure diagnosis. There are professionals who can do this kind of assessment. So our committee, we didn't do that. We would go and talk to someone who seemed to have a problem. But then the dean had given us authority to say to this person, if you want to keep working, you have to go for an evaluation. And so they could pick another institution, but not in our, they would have to go out of state to another place to get an assessment, which usually would take 2 or 3 days. And then experts, people, with this is their profession, would send them back with recommendations. Now, the typical recommendation is not an easy one. Begins with sending them to a place that treats them in a facility for 1 to 6 months, right? I stayed 6 months in a place. So this is a real interruption in people, and just like they're on the railroad. If this gets out, it's going to ruin their life. Of course, if they don't get help, it ruins their life more, or they end up dead, or they end up insane. And I have known many doctors in all these years who died because they would not cooperate. But it's not easy. It's not an easy thing. And so we had from the dean authority to present this person with what's called a consent agreement. If they wanted to work in our medical center, they had to agree to the conditions. They were free to go, they resign, leave, go to some other place, and some would do that. But if they wanted to stay, they had to agree to this consent agreement, and then we became their advocates for them to return to work with monitoring. And monitoring meant that they had to identify somebody in the workplace who would see them every day and report, and agree to report if they weren't doing well. They would see a psychiatrist once a month, not that they were crazy, but just to see how they were doing. They would meet with our committee once a month so that we could talk to them. They had to attend usually 4 AA meetings a week, and then they had to submit to drug and urine testing at any time that we requested it. And that, that's a lot. And it was a no second chance program. If they drank, if their blood test was positive, then they would be terminated. And this was all legal in the consent agreement. Now, it may seem like we're beating them over the head with a bat because they have a disease, right? The disease of addiction. But the disease of addiction kills people. And so as it turns out, people who go through this do the best. And then my last thing I'll say is about Alcoholics Anonymous, which is an entirely grassroots movement. That is, there are no officers, it's just groups of people who make a commitment to help other alcoholics. So in this little town, Morgantown, we have 60,000 people and 28 AA meetings a week. And this is true all over the United States. And no one pays, it's free, right? It's free help. So how does it work? You know, psychiatrists have treatment centers and they often do good things. And many alcoholics also may have other diagnoses. But I wonder if you've heard of the Cochrane Group. I didn't see anybody's picture, but so they've been around over 20 years, and it is a very sophisticated organization in England that does meta-analysis of all the information on a given subject. So let's say they decide they're going to monitor the treatment of macular degeneration. They'll get a few experts to serve, and every month they get, you know, more papers that have been published in the English literature. And then the Cochrane Group has a very sophisticated statistical programs to keep adding data. Now it's not perfect data, right? It's not prospective, double masked, double blinded. These are often not, you know, someone reports so many patients. But the notion is if you add them all together, they may not be perfect papers, perfect research. You add them all together, it's better than nothing. And furthermore, if it's done in a systematic way, it's better than just asking an expert. You know, we tend to say, well, who's the biggest expert on whatever? And then say, well, what should we do? But so the Cochrane Group, and so they do it's a very large, many issues in medicine. But they decided that they would undertake the assessment of the treatment of alcoholism. And a few months back, their first report, which is very extensive review of data from the entire English literature, reported that Alcoholics Anonymous by itself was superior to or equal to any other treatment program. And it's free. And it's present everywhere in the United States and in 130 other countries. And so these two men that started in 1939 have saved millions of lives. And that is not an exaggeration. That is the number of people at any given time in this group is like 3 to 4 million worldwide. And it all runs because people who have been helped turn around and help others. So it's been 38 years. Twice each week, I go to a meeting and try to talk to people that come in thinking maybe they have a problem with alcohol. Although now we have to use Zoom, which is harder. So, I know the idea that this is a disease rather than, an acquired, thing. I think people are born with this, and then if they drink or drug a certain amount, it will be activated. And that if they are in that category, it is almost impossible. It is impossible for them to stop by themselves. It's like someone had epilepsy and you said, I want you to stop having seizures. Just don't do it anymore. And you didn't provide them with any medication or treatment, just, talk to them. So these are sort of the foundations of the program. It still exists, but I am no longer the leader of it. But you see, your 5 years for physician, the 74% success rate, another 16% of physicians who decided to quit practice. Well, sometimes because they're anesthesiologists or, very high risk situation. Anyway, about a 10% failure rate. Now, that's actually pretty good. So this is not oculoplastics, but you agreed. I sent the topic and it was accepted. So I guess that means you're okay listening to it. So thank you again.
Excellent. Thank you for sharing
Thank you
your
very much,
experience.
John. This was a shaking talk to hear. It's something that everybody should know, and it's something that we usually don't talk about, as you already know.
Yeah, I can guarantee you, it's thought to be about 10% of doctors will have an alcohol problem sometime in their career. So every one of you will see these people. Now you may not recognize them, but it's not 1 in 1,000.
Amazing.
Only a great human can speak about this. Thank you. Thank you. Martin, I will show only a picture of my presentation.
Yeah, go ahead.
Dale, Dani.
Compartir
Daniel,
pantalla.
adelante. Sí,
Vos.
vos.
Compartir.
Sí.
Compartir pantalla.
Una foto nomás. Bueno, a ver. ¿Cómo va adelante esto? Okay. This picture here, round by red, was given to me as a present in 1991 by John Linberg in Campinas. First time I met him. That's gold for me. Thank you, John.
You're welcome.
And this is the endoscope I have today. I changed the endoscope, but the rest is the same. It functioned perfect. Thank you very much for all, for being with us. 2 beautiful presentations. All the years we make oculoplastic 1 by month meeting, and next year you will invite it to speak about story of endoscope or what you want.
Thank you. I will look forward to it.
It's a pleasure.
COVID, we have to get.
This is really a tribute for you. You are a great.
Wow. Well, thank you very much for all of you for being up so late. We apologize for what happened. There is always a first time.
We forgot. We forgot.
This is our first time in it. Thanks for your amazing talks, John, and for sharing your personal experience. Really, it's something hard for every person, and we really appreciate for what you did. And well, thank you, Daniela, for our translator, to the Argentinian Council of Ophthalmology for giving us support, and Mariana. And well, John, again, it was a great honor to have you here, and we hope you can come and visit us in Argentina pretty soon.
I hope so. COVID.
Well, Danny, if you want to say some words to close this,
No.
go ahead. And thank you, Danielle, for stop your talk. I know it's hard when we prepare, but we're running out of time, and no one asked Daniel not to give the lecture. He just offered himself.
Yeah.
But
We know it's a great
Jones,
picture.
Jones know a lot about Jones tubes and all these things. Thank you very much, John. It was a great pleasure. It was an honor for us. Thank you very much.
I'm going to add it to my list of
And
wonderful experiences.
af-
Because
after the-
things go around. It's like a big circle. Anyway, I'm very happy I could come back.
And after the virus, we hope to take you to Las Cataratas or to Bariloche or to Seven Lakes or all the places you was here. Thank you very much. Great
right.
pleasure. Great
Thank
pleasure.
Thank
So,
you.
John, thank you very
All right.
much.
Thank you, John.
Bye-bye.
Bye-bye.
Thank you,
Thank you
John.
very much.
Bye bye.
All the best. All the best.
Bye bye.